afternoon. This is Dr. Alasio speaking to you from the Cytodiagnostic Center in White, New York. Today's webinar is webinar 4. This is the 4th in our 6-part series of the Integrated Diagnostic Approach to Thyroid Nodules. And this webinar is, the topic is case presentations from our diagnostic center. Director of Cytology and the Cytodiagnostic Center at Cairo Diagnostics in White Plains, New York. I have held various positions, including a staff pathologist at a major laboratory, as well as being a clinical associate perfecter and director of cytology at SUNY Downstate in Brooklyn, New York. My credentials are that I received my medical degree from Mount Sinai. I also did my pathology residency there. I did a fellowship at NYU in cytopathology, where I trained in a specialized technique of fine needle aspiration biopsy. I'm board certified in anatomic pathology and cytopathology, and I hold certification from the College of American Pathologists in ultrasound-guided FNA, and currently I am pursuing endocrine certification in neck ultrasound. Center, we promote an integrated diagnostic approach to all our cases. We see patients here. We clinical correlation in our everyday patient care. We also correlate findings with ultrasound and cytology, which allows for an integrated approach. We do immediate specimen triage of all specimens that we procure here in the Cytodiagnostic Center. And through this way, we are able to determine if samples need to be taken for further testing, such as molecular testing or flow cytometry. So there is no need for a patient to return for another FNA. What tests we're going to do, and we take all those samples on site. Getting positive findings, we report directly to our referring physician. Webinar series of the Integrated Diagnostic Approach to Thyroid Nodules. We offer 6 sessions. I have covered topics including thyroid cytology, ultrasound features of thyroid nodules. In the last session, we discussed the American Thyroid Association 2014 guidelines in the diagnosis and management of differentiated thyroid cancer. Today, we're talking about interesting cases from our Cytodiagnostic Center, both thyroid and non-thyroid in origin. And in future sessions, we will be discussing molecular testing for our Bethesda 3 or 4 and indeterminate nodules. We are talking about case 1 first. Is a 52-year-old male who has a heterogeneous spongiform thyroid gland on ultrasound. Right thyroid nodule is 1.3 by 1.8 centimeters in 2 dimensions, and there's 1 Doppler flow seen. So we've already discussed all these in the ultrasound session, and just grade 1 Doppler flow means it's just basically no flow in the nodule. But because the size of the nodule was 1.3 by 1.8 centimeters, it's actually fairly large. We did an ultrasound guided fine needle aspiration biopsy. So see the here. Thyroid gland, which is located here, and it looks a little spongiform in appearance. There's a heterogeneous looking echo texture in a fairly circumscribed nodule. On aspiration, what I saw on a different quick stain or basically follicular cells that appear reactive, meaning that they look, have some degree of pleomorphism, which can be seen. Like this one might be a little bit bigger than this one, but overall they're spaced out. But here you have the follicular cells are seen lymphocytes, and these are lymphoid tangles because the new lymphocytes are very fragile, and so they get crushed upon smearing. Therefore, they are on slide because during the action of smearing slides, the lymphocytes get crushed, and so you get these lymphoid tangles that appear on cytology. And all this in the background is stuff is blood. But however, I did see on another slide just this colloid and this dark purple stuff that actually looks like it's kind of folded. So you can see kind of a three-dimensional quality to the colloid. And like maybe some lymphocytes here and there, and it's also like some peripheral blood. So I made a diagnosis of colloid-rich adenomatous nodule in a setting of chronic lymphocytic or Hashimoto's thyroiditis. In cases of Hashimoto's thyroiditis, the thyroid parenchyma appears spongiform. And it appears heterogeneous. There are areas where nodules definitely exist in Hashimoto's thyroid patients, but they must be differentiated from pseudonodules, which also appear in cases of chronic lymphocytic thyroiditis. And these pseudonodules are usually composed of lymphocytes, and usually a heterogeneous population of lymphocytes and lymph follicles, which appear nodules in standing Hashimoto's thyroiditis. Even the nodule itself was a grade 1 on Doppler flow. Hashimoto's in general can be hypervascular on color Doppler. You see cells admixed with lymphocytes, as I showed in the previous slide. Sometimes the follicular cells may appear typical, which is on cases with Hashimoto's thyroiditis, but this is more of a reactive atypia and not neoplastic. We've seen our Hürthle cell metaplasia. It was not seen in this case specifically, but metaplasia is certainly seen in cases of Hashimoto's thyroiditis on cytology. There are occasions when a nodule or pseudonodule is aspirated on guidance and you only see lymphocytes without a follicular cell component. That may mean also that a pseudonodule was aspirated and there are actually no follicular cells seen. Or this could also be a clinically florid phase of Hashimoto's thyroiditis. Is a 49-year-old female where the ultrasound of her thyroid gland showed a complex nodule in the left lobe, again with grade 1 Doppler flow. So nodules can be ultrasound, and usually there's complex. We mean it has a cystic and a solid component. So you want to biopsy the solid portion of the nodule and not so much the cystic portion, but that hypoechoic area versus hyperechoic area. The hypoechoic area may also be colloid and not necessarily a cystic component. Colloid or cystic, and the solid portion or the hyperechoic portion could be also the solid portion, which could be cells. So FNA. DNA of this left thyroid nodule. And so you can see that the nodule actually is fairly well circumscribed, but there's some hypoechoic areas. You have some isoechoic or even hyperechoic if you're comparing it to muscle here. It looks hyperechoic compared to muscle. There's no calcification per se, but you can see areas that are a little bit more brighter in echogenicity. Now, this could be either the calcification or macrocalcification in this case, or it could also be inspissated colloid that causes a brighter appearance. Or these flat sheets of regular cells that kind of have a little more cytoplasm to them, which make me think that this could be a Hürthle cell in origin. And when you look on a Pap stain, these look more Hürthleoid in appearance, in that they have eccentric some higher magnification. You can see actually some areas that where there are nucleoli. You may not be able to pick it out here, but in other foci, here's maybe a nucleus. There's multiplication, which is common also for Hürthle cells. You can have that definitely, but these look same case, and you can also see that there's this granular cytoplasm with eccentric nuclei, which will make you think that these are Hürthleoid or Hürthle cells. This background is blood, and these are just some which are peripheral blood and some lymphocytes. So the population of Hürthle cells that was relatively significant, and there were also benign follicular cells present. I call this a lesion of undetermined significance. This could either be plastic nodule with extensive Hürthle cell metaplasia versus a Hürthle cell adenoma. It's rarely a carcinoma, but for this case, I call this a Bethesda 3 Hürthle lesion of undetermined significance. Specific ultrasound findings, to my knowledge, for Hürthle cell nodules, but these nodules are usually solid, or it could be complex, but usually solid, and the borders may be ill-defined. The money is in the cytologic findings. Hürthle are seen either as a single population, which makes you think maybe this is more along the lines of a neoplasm, and by neoplasm I mean benign neoplasm, such as an adenoma, versus malignant neoplasm or carcinoma. It doesn't always have to be a malignant neoplasm. By neoplasm could also mean something benign, such as an adenoma, or it could be mixed with follicular cells. So you can have single populations or mixed populations with follicular cells. But if you don't have lymphocytes, but cells, you may think of a Hürthle cell nodule or Hürthle cell lesion instead of metaplasia. And because these nodules are solid, you may have a genuine lack of colloid is seen in this nodule. A 61-year-old female, and actually out of the thyroid, and we're moving into the other areas of the head and neck. I thought I'd kind of explore this a little bit with you, because not only do we do thyroids, which are most of the cases that we see, but really we also see a lot in general, not just thyroid, and this can mean either, parotids, lymph nodes, mandibular glands. So these things are also fair game in our Cytodiagnostic Center. So this lady had a left parotid gland with a 2-centimeter, well-circumscribed, freely movable nodule. This patient reported having this nodule for over 10 years. So this is actually a very significant clinical history, a long-standing history of this nodule versus this nodule up 2 months ago. So this is less worrisome for malignancy than the nodule that just popped up. So our suspicions, we performed an ultrasound-guided FNA. Ultrasound, the left parotid gland, and right in the middle of the parotid gland is this circumscribed hypoechoic genius that measures 2 centimeters at its greatest dimension, and this appears in the left parotid gland. The FNA biopsy, the diagnosis was immediately apparent. What I saw under the microscope on diff quick stain is this chromatic mixed with these very small little cells in here, admixed also with maybe some inflammatory cells or lymphoid tangles. And then in the background, we have also these cells, which are called epithelial myoepithelial cells, which are very immature cells. So in all of that, epithelial myoepithelial cells even seen better on a pap stain. And this is the matrix that I was also talking about that appears blue, wispy in appearance on a papinicolau stain, as opposed to, if you go back, it's this magenta or metachromatic matrix. It's blue on papinicolau stain. And here are these same epithelial myoepithelial cells, and here are more of them right here embedded. And all of these features make this readily apparent. And here are foci actually of this lesion. Lesion is much more cellular. There is much less matrix. There's a little bit up here, but it's very, very cellular here. These cells kind of look a little funny in that, you know, there's a degree of pleomorphism here, but it's closely actually very, very bland in appearance. These are the same epithelial myoepithelial cells. What this is a cellular pleomorphic adenoma. And pleomorphic adenoma is a benign neoplasm, usually in the parotid gland or major salivary glands, and they can be very cellular, or they can actually be paucicellular or not so cellular, depending on the amount of matrix that they have. Ultrasound, this is usually a circumscribed lesion that is tabulated in some very distinct borders or solid masses. They have what we would call a heterogeneous echotexture because they're combined both of cells and matrix. So the matrix is referred to as a chondromyxoid matrix. So there's almost like a cartilaginous component. So these nodules actually on physical exam are going to feel very firm and freely movable. But this actually can turn out to be a very difficult aspiration, and that's actually one of the clues to the diagnosis. Because if you don't get a very cellular or juicy, for lack of a better term, aspirate, you might think pleomorphic adenoma with a lot of chondromyxoid matrix is what you're dealing with, because these are not usually mentioned this paucicellular aspirate. There's usually mixed in these tumors. One component is the chondromyxoid stroma, which can be seen explained that quite extensively. The other is the epithelial myoepithelial cell component, which can vary in degrees of cellularity. You may have a lot of cells in a cellular variety of pleomorphic adenoma, or you may have not so many cells, depending on where you sample. And the cellularity definitely varies depending on how much stroma versus the cellular component exists. That we have, again, we're moving out of the thyroid and into the neck as well. This is a 76-year-old man who has a heterogeneous nodule at the level 2, so that's very high up in the left neck. 1.9 by 1.5 by 2.5 centimeters with internal vascular flow. FNA was performed. This is the level 2 neck mass, and here it is as you go up. This it kind of looks like it's multi-dimensional. It has maybe a different bunch of components to it. Like maybe this is not one mass, maybe this is a few lymph nodes that are kind of matted together. There are heterogeneous areas. There are some hyperechoic, some hypoechoic. And this, if it's a lymph node, there's no fatty hyaline that's seen. Upon aspirating this lymph, certainly, yes, it is a lymph node because I see that there's crushed lymphocytes here. But in the midst of all these crushed lymphocytes, I see these very large visceral cells that, and if you look and see, compare the size of these nuclei to the size of red blood cell, these cells are enormous. This is one of the clues. You also see that there's nuclei, although I'm going to show you in the next slide that there's a better view of it. But you can see also that there's a very plasmic ratio, a key feature. Here, the ratio is better seen. It's a very high ratio. That means the nucleus is very large, and the cytoplasm is very small. This is a very suspicious finding. You can see even the nuclei are here. Okay, these cells are kind of clumping up in a three-dimensional way. Makes a person looking at these slides think that this is not a benign lesion. As we see this pap stain, you can see the nucleoli and the clumped chromatin a lot better. You can also see that there's bizarre shapes of the cytoplasm. Again, if you compare the size of the nuclei to the size of red blood cells, you can see that maybe you can fit like 5 little red blood cells inside this cell nucleus. And that makes it actually a pretty large nucleus. Carcinoma, non-small cell type. This patient came with a history of a lung nodule that and so had appeared with the level 2 neck node that was to be metastatic carcinoma, but that needed to be confirmed prior to any treatment being given. Appearing lymph nodes, they're usually it can be a very large mass on ultrasound. Some heterogeneous echo texture, areas of necrosis that can be cystic, versus solid foci, which are the more cellular areas on cytology. If this is an infiltrating focus, you may see also they may be lobulated in appearance, and that's how they're infiltrating. The lymph nodes can be matted together in the neck. I've seen this before, especially with squamous carcinomas. They can be all matted together, so you're not looking at just one lymph node. You're looking at maybe 4 or 5 lymph nodes. They're all matted together. Normally, you see a hilum, and that's kind of this hyperechoic line in the center of the lymph node, which is the fatty hilum. And lymph nodes, whether it's a metastatic focus or a lymphoma, the hilum is absent. And if you're scanning using the ultrasound, these lymph nodes will appear taller than wide, as opposed to wider than tall. If a lymph node is wider than tall, it's mostly, or it's mostly a benign lymph node. However, when lymph nodes grow and they don't respect the tissue planes and they become taller than wide, it becomes a suspicious lymph node. And when you perform a color Doppler on suspicious nodes, you will see an abnormal vascular pattern, meaning that usually you see hilar flow and you need some peripheral flow, but the lymph nodes usually have malignant. They usually have an abnormal flow. You may not have hilar flow, and the flow appears more chaotic in a lymph node. So the aspirate will be cellular, or however, you may have a necrotic background, and you can tell a lot of times when a lesion is necrotic, or when you stuck your needle into something necrotic, that when you express it onto the slide and you smear it, it actually will smear very easily. It's all necrotic tissue. Tumors, or if you have a lot of cells, it's malignant. It actually feels more gritty when you are creating the slides from experience. So how do you know that you're in a lymph node, in a malignant lymph node, rather than in a primary focus or versus metastatic? Well, if you see lymphocytes and malignant cells, then you can say, okay, this is most likely a lymph node. If you only see the malignant cells and nothing else, that's either a completely, that could either be a primary focus, or it could be a lymph node that's completely replaced by metastatic disease, and in which case you can't really tell. But if you see lymphocytes in a significant number, along with the malignant cells, you can say that this is probably a metastatic focus rather than a appear pleomorphic, then in the way that lymphocytes would be a heterogeneous population, meaning they're all different lymphocytes in various degrees of maturity. Pleomorphic malignant cells are usually the epithelial cells. This is what I'm talking about when they're epithelial. I'm not talking about when lymphoproliferative or lymphoma, leukemia within a lymph node. I'm talking about epithelial and non-lymphoproliferative cells may appear more pleomorphic. Okay, and if you know what the primary tumor is, these malignant cells will obviously look like it. And if you create a cell block at the same time that you do the aspirate by expressing a needle pass into formalin or putting a blood clot obtained from the tumor into the formalin and make a cell block, you can do immunohistochemistry in order to determine what cell of origin is this tumor. And that can be very helpful. Studies such as molecular studies or FISH, or in situ hybridization, meaning FISH, on a cell block as well. So those become useful tests. So if you do suspect a metastatic focus, it is a good idea to get enough material at the time of aspiration to create a cell block so that other studies can be performed. Or in the case of a lymphoproliferative disorder, which you'll see coming up in the next case, that you can get enough specimen for flow cytometry. case. Of a 58-year-old female who had lymphadenopathy. So by lymphadenopathy, that means more than one lymph node is involved. In this case, it was a left preauricular lymph node, which was about 2 centimeters, and a left supraclavicular lymph node, which was a little bit less than 2 centimeters as well. One of the time also having an enlarged lymph node but we didn't do a biopsy there. We just did the biopsy of the left preauricular and the left supraclavicular. So this was the preauricular or parotid lymph node, and you can see this enlarged circumscribed mass that you could see some posterior enhancement. It's hypoechoic, and see also the supraclavicular lymph node, which also has the same features of posterior enhancement. It's well circumscribed. Is a little bit slightly of reverberation artifact. And other than that, it looks hypoechoic in nature. On fine needle aspirate, and this is one of the specimens. And what you can see here, obviously, is that this is overall there are small, large lymphocytes, right? Medium size, and there's some smaller ones. And if you compare what cells look like, you know, there is more than one population, but overall there is a small to medium lymphocytes that look very, very monotonous, and they're kind of spread out. There's no clumping of the cells the way epithelial cells would be clumped together. There's also no body macrophages, which you would expect to see in a normal lymph node. There's certainly of monotony, which is more exhibited by this Papa Nicolau stain smear. So you do have some larger cells which are here, but overall there's this small that kind of clumpy chromatin. You see any tingible body macrophages. You don't see lymphoid tangles. You don't see lymphofollicular arrangements. You don't see the quote-unquote normal things that you would see in a regular lymph node, and also you don't see cells. So this makes me suspicious. Another view, seeing that same kind of thing. There are larger cells here in this field, but still the same small to medium-sized lymphocytes are seen. I think this is probably the supraclavicular lymph node here. The same thing, and even these and all of these lymphocytes here that are just bubbling up and this monotonous population look abnormal. And they just have this appearance. So flow cytometry at the time. So the immediate assessment was enough to make me suspicious. I took samples for flow cytometry from the same lymph nodes that the ultrasound guided biopsy. We did flow cytometry, and it was the same on the same night, and this came out to be a B-cell non-Hodgkin's lymphoma, and it was determined that it was a follicular lymphoma. So also at the same time, we did cell block, and we performed immunohistochemistry, and the cells expressed CD20, BCL2, and BCL6. So the of follicular lymphoma was made on an ultrasound fine needle aspirate, and flow cytometry was confirmatory. And this overall was a very, very helpful case, both for learning purposes and also because of the speed of diagnosis, the patient was able to be put into treatment pretty much every day. I mean, just going over again what you see on an ultrasound of suspicious lymph nodes, you would see this enlarged lymph node that doesn't have a hilum. Okay, the fatty hilum that is a normal lymph node is not present. The lymph nodes appear hypoechoic with an abnormal vascularity on color Doppler. And just to review the cytologic findings, aspirates of abnormal lymph nodes have a lymphoproliferative process associated. These abnormal lymphocytes may appear monotonous. No follicular architecture that can be seen. Also, no tingible body macrophages or features of benign lymphocytes, even though benign lymphocytes may be present, but in a lymphoproliferative process, you may not have that. That's not the features that's going to jump out at you. Features are existing in your aspirate. When you evaluate it, you should be able to take samples for flow cytometry. If that's available, then you should at least take some extra samples to make a cell block so that you can perform immunohistochemical staining. So in conclusion, all cytology work hand in hand in making the correct diagnosis in ultrasound-guided FNA cases. So you see the patient, you perform you do the cytology, and you put it all together, and that's really what the integrated diagnostic approach is all about. And it can be applied not only to the thyroid, but also to anywhere you can perform these aspirates. Ultrasound-guided FNA is the appropriate test to rule in benign diagnoses because it is non-invasive, the procedure, and it gives immediate satisfaction to the patient and the operator. Ultrasound-guided FNA is ideal to triage cases of suspected malignancy in that additional samples are taken for extra studies. So, ultrasound FNA is an extremely useful procedure for medicine. It is useful for the patient. Then they get the diagnosis right away. For the referring physician, if in the case where the findings are suspicious or malignant, then the patient can be put into a treatment protocol immediately. It's very satisfactory for the pathologist or clinician performing the FNA because when it's evaluated, you have immediate satisfaction that your diagnosis can be made on the sample that you took, as well as any material that you may need for ancillary studies, and there's no need to call the patient back for another FNA so that you can take more samples. So, and be applied not only to thyroid, as I've demonstrated today with my cases that are thyroid and not thyroid, in the parotid and lymph nodes, especially. These are areas very amenable to ultrasound-guided FNA, and the rules of integrated diagnostic approach and its principles applies as well. So listening, and I hope you come back for session 5, where we will talk about molecular diagnosis in thyroid nodules.